All right, good afternoon and welcome to today's solution session hosted by ERS. My name is Bernie Hayaski with the Executive Office. And here today are representatives with Prescription Care Management. They're here to talk about some of the pharmacy-related services that they offer. We're going to lay out the ground rules for today's solution session. PCM will have up to 45 minutes to present their services to the group. After that, we will have at least 15 minutes of question and answer from the group. And at the conclusion of the hour, then we'll be done. We'll be wrapped up. Today's session is being recorded, so please speak up whenever you are asking a question or making a comment so that we can capture that on the recording for those who watch it after today. With that, I'm going to go ahead and turn it over to the representatives from PCM for their presentation. Garrett.
Thank you. Hi, I'm Garrett D'Antoni with Prescription Care Management, and today we're going to talk about a couple things that PCM is doing and some new things in the industry that we're getting involved in that we think is really the future of prescription medicine and prescribing. And so with that, we'll go ahead and get started. All right, so what we're going to cover today, we're going to cover what PCM, what we call our savings program, kind of care coordination, care management program, which we feel is the key to pharmacy savings, where we're interacting with physicians and really what we're doing is we're showing a drug that, you know, the physician prescribed and a cost-effective alternative and the price of those drugs. And, you know, it's a lot of times it's drugs that have been on the market for 20 years, and it's the question of what's the cost between the new medication and the old medication. From there, we're going to cover precision PGX, pharmacogenetic testing, which is what we feel is kind of the future of medicine and how, you know, medication will be prescribed in the future. So we'll cover and touch on PGX. And then the last thing we'll touch on is our analytics solution. And really is what we're doing is we're diving into the data and we're presenting the data in a way that creates a discussion within an organization or in a group that says, okay, this is where the money is, this is where maybe the attention needs to be focused on cost savings. So with all three of these approaches, we look at different levels of savings, but all three have significant savings tied to them. So from there, we'll cover the PCM savings program. And really it's like I said, engaging doctors to save money. And the key to savings with this, if the doctor never prescribes a medication, it doesn't cost anybody anything, the group or the member. And so what we're looking at is say, okay, what's the true cost or what's the lowest net cost drugs within a class or within you know, a therapy that says, okay, doctor prescribed drug A, drug B has been on the market for 20 years, it's a tenth of the cost. Is this a good medication for that member? And so we're always looking for quality of care. We're always saying, hey, look, you know, do the best thing for the patient, but keeping cost in mind. And we present that information to the physicians and say, okay, drug A costs $1,000, drug B is available for $200. Is this an appropriate switch for the member? So really with these cost-effective alternatives, there are medications that have been on the market for a long time. It's not Western medicine. It's not something that's over the counter. It's just another choice of a cost-effective quality medication. So with that, the physician can look at it and say, okay, yeah, they're both great drugs. I'm going to go with the lowest cost alternative. So how does PCM find savings? So our process is very retrospective. In that way, we limit or reduce disruption. By looking at the data retrospectively, we're able to identify cost savings opportunities. We're able to reach out to the physician and say, hey, you prescribed drug A, drug B is a great choice. Here's the cost difference. Would this be appropriate for the member? If the physician says, sure, that would be great, then and only then do we reach out to the member and say, hey, look, this is a choice that your doctor approved. Would you like to make the switch? In that case, the member says yes, Then we facilitate everything from getting a new script to getting it to the pharmacy to making sure that the complex industry, we're helping navigate that, and the ability for the member just to say yes or no, go to the pharmacy as they always do, and get a lower cost medication. So from that, not only the member with a cost savings from a copay, but the plan will save as well from the reduction in the medication. So the way that PCM starts a program is we do a free analysis, and we look to make sure that there is cost savings opportunities within a group. So from here, we'll take the data, we'll run the analysis and say, okay, at 100% of the switches, in this case, there's $43 million available to save in your program. We're not going to get 100% of the physicians and the members agreeing to say, sure, we'll take all of your recommendations. It's not possible, not going to happen. So what we do is we start to break that down and to pare it down to say, okay, what percentage of your population, the green that you see up on the board, the 50 to 60% is just our statistical average between all our groups of all sizes. It's a blended average between the physician and the members. And from there we say, okay, so let's talk more in the $20 million range. And from there, we're going to start to net that down, take our fee out of it, take the rebates out of it, take any generic launches that are coming out that might, reduce those savings costs, and present a net savings number. From there, we're going to take that and say, okay, is this worth going after? Is this enough money in your program to say, yeah, we want to spend the time and the effort to put this in place? So from there, the ROI is what, we're really trying to get as high as possible, obviously. But that's a pretty, as you can see, a pretty standard number for us. We're looking in the 300, 400% ROI to really make it worth it for the group. And also for PCM to put in the time and the effort to communicate with the physician. So these are just some of the savings examples. A lot of these 400, 300, 500% ROIs. These programs have been in existence from 2, 3, 5 years. The one in the bottom, new university system that we implemented, already have a 234% ROI just in the first quarter of running the program. So how does PCM identify savings? So it's our job. That's what we do. Our pharmacy team pretty much every day is looking for new drugs that have come out into the market. The opportunities through mining the data, looking for new opportunities, looking for opportunities, whether it be paying cash for the drug. We're seeing a lot of times it's becoming cheaper than actual covered medication within a group. Looking for the demographics. So diabetes is becoming an issue with every plan, and really looking at where is the cost savings opportunities within that group, within those disease states, within the population. So obviously specialty drugs, high cost drugs are another issue. And then what we're really excited about is the savings from pharmacogenetic testing. So pharmacogenetic testing, right drug, right dose. If we talk about preventative medication, which is kind of the thing to do these days, so if we can prevent diseases, if we can prevent hospitalizations, well, we can now prevent a lot of adverse events with drugs. So the traditional model of prescribing medications is trial and error. Put you on a medication, we'll guess on the dose depending on how bad we think the disease is, and we'll see if it works. And if it doesn't, come back, we'll switch the medication, we'll change the dose, and it might take months, it could take years to make sure that that individual is getting the right drug at the right dose. So when we talk about pharmacogenetic testing, we're really talking about the metabolism of a drug, how we break that drug down. We have to break the drug down to be able to get the intended effect. So if 48% of the population cannot metabolize a drug normally, then look at the person next to you. Which one of you will not metabolize that drug correctly? And all of a sudden, now you see a commercial with 10 minutes of side effects. A lot of it has to do with the way the drug's broken down or not broken down. So if I can't break down a drug, toxicity levels can build up, side effects can start to appear, and a lot of that can be avoided. And this is the exciting part of it is, you look at the numbers with adverse drug events, and we say between hospitalizations and we see the number of ER visits and productivity, and so it's on and on and on that adverse drug events or these reactions or these side effects that are caused by medications. Now all of a sudden, the savings just keeps compounding when we can reduce those and we can eliminate those. So personalized medicine. This is what PGX is. This is something where you look at a medication, it's prescribed based on normal metabolizers. Now we're looking at, okay, well, if only half of us can metabolize a drug correctly, then what's the next step? Well, personalized medicine lets us say, hey, look, I'm an ultra rapid metabolizer of this drug. I need a lower dose, or I'm going to get too much of the drug in my system. Or I'm a slow metabolizer of that drug. I'm not going to get the desired or intended effect. So now that we have personalized medicine, we can look at genes and how those genes interact with that drug. We're able to say, okay, we know what drug you need to be on, and we also know what dose you need to be on. So from day one, we can eliminate months to years of trial and error, of wasted time and energy and doctor's visits and lab tests and medications that aren't needed, and all of a sudden start treating the disease or treating the issue from day one. So PGX, it's really just a simple mouth swab test. We'll go over that in a bit on how the test is taken. But really what we talked about is eliminating the trial and error prescribing. We're reducing and hopefully eliminating adverse drug events. And really what we want to do is just have better outcomes from the medications. So with PGX testing, what's the impact? How many people are actually being changed? If we say 48% are metabolizing correctly, what does that look like? And as you can see, warfarin is probably one of the biggest ones that individuals have issues with. And you can see from PGX testing, 96% of patients, there was a change made in the medication or the dose. So big number. Pain meds, another big one. And so you can see with a lot of commonly prescribed medications, which are commonly prescribed in your group, the percentages are high for a change in the medication or dose. So this is getting a little scientific, but it really wanted to show you guys that there's one gene that's been identified that affects about a quarter of the drugs out there. Just so if you have the gene or don't have the gene, it's something that's a concern. That says, okay, if you do and you're not metabolizing drugs correctly, how much of it does it affect? The opiate epidemic. It's an issue everywhere. It's something where if you think about being hospitalized, going for a surgery, an ER visit, and you can't manage the pain, right? Hospitalizations increased, lengths of stays increased, and the overall just experience is a negative one because you can't control the pain. Now, when we talk about improved pain management with PGX testing, so if we all go in and have surgery and we're prescribed a medication, and some of us are slow metabolizers and we're not getting enough of it, then it's not doing us any good. If we're ultra rapid metabolizer on it, a low dose of it, either an overdose or getting too much of it and causing addiction. So when you talk about the profound effects in the opioid epidemic in this country is tied to how our genes metabolize a drug, you start to wonder, okay, how can we help this problem? How can we solve this problem? This is one way that needs to be looked at, to know pre-surgical prior authorizations, right? So you know exactly how you're going to treat the pain, with what drug, with what dose, to make sure you're not creating addicts. If you go back and you look at the bottom, the difference between a 10-day supply and a 7-day supply for long-term users, taking it 3 extra days, you increase significantly the chance of addiction. So with that, the overall experience with opiates and with pain medications is, if you can reduce the hospitalizations, we can increase the care, get you better faster, get you to work sooner. All of a sudden your costs start to decrease in every aspect of it: absenteeism, productivity, quality of life. So there are significant cost savings when you start to look at PGX associated with just hospitalizations, surgeries, and managing, musculoskeletal pain. That is a big problem. A couple case studies. So you have Renata, 35-year-old female, on multiple medications. You can see the first one, she's negative for normal metabolizer of it. Omeprazole, it's not going to work. So consider an alternative treatment for that. And then ibuprofen. And slow metabolizer are not going to get the intended effect, so not going to be able to control pain, as well as maybe another drug. Ajit, 40-year-old cancer patient on multiple medications. Seeing this a lot with disease states and depression, managing and dealing with the drugs. And depression is one of the main categories that PGX is testing for. But you can see here, with a decreased effect of methotrexate in treating the cancer, it's not going to be as an effective a treatment as a higher dose. So this is something that the information is powerful. And to be able to say, okay, we know that this isn't going to work as well, we need a higher dose from day one versus waiting 6 months, 8 months, whatever it may be, trying to figure it out day one. So Brandon, this one's scary for anybody that has young kids, such as myself. Is kid falls off a bike, breaks an arm, goes into the ER, trying to manage the pain. Tylenol, codeine seems pretty reasonable. This individual, Brandon, a 6-year-old boy, has a gene that's going to metabolize that drug too fast. Too much of it's going to get into his system, and he's going to OD. So it's something where, do you go out and run out and get every kid tested? No, but I think there's, as an industry, to understand that is a possibility, and it is gene related, not so much the drug related. It's something that needs to be considered and discussed. The PGX process. We have tried to make this about as simple as possible, to where we've incorporated a telemedicine component to it so that the test can be taken at home. And really what we've done is our telemed partner has trained the physicians on PGX testing, and so it gives the member the ability to sign up for the PGX test, speak with the physician that says, yeah, this is medically necessary, you should get the test. A kid is sent to your home, a simple oral swab, sent back to the lab. The PGX test is processed, the report is given, a follow-up consultation with the physician to go over the results, to discuss it, and even to say, hey, can you talk to my primary care about this, or a specialist about this? And so that everybody is on the same page of what those results are, what the drug and the dose should be. And then from there, That test is kept in a portal so that it can be accessed down the road. You're prescribed a new drug a year from now. Look at the test, it says, yes, this was a PGX drug that was tested. Here's the ones you should be on, color-coded red, yellow, green. So you'll know, or the physician will know right away that says, you know what, I cannot metabolize this drug, I shouldn't be on it. And so as new drugs come onto the market, they're added to this. This is a test that stays with you for years and years and years. You're able to go back, access, and say, okay, now I know which drugs I can and can't take and what doses those should be. So how does PCM identify PGX candidates? So to go out and say, hey, let's test the entire population, the sticker shock of that would be a little high. It'd be a little expensive. So what we're doing at PCM is we're following the lead of the FDA. The FDA has issued black box warnings on about 160 drugs. Those black box warnings actually state that you should have a PGX test done, and it's highly recommended that one's done. And so we're looking at those, we're reaching out to members and saying, this is where we're going to start. We're going to start with the highest of high-risk populations. And those people, as those tests are done, savings are generated, pay for the next group of high-risk people and so on to work through your population. With that, polypharmacy, we're looking at 4 or more drugs. So with 1 PGX drug and 3 other drugs taken together by an individual, we're identifying those patients as high risk and reaching out to them to say, you know, this is something where adverse drug interactions and adverse drug events, plus you may be able to reduce the number of medications. If that first medication is causing side effects that we talked about earlier, we may be able to change that original and get rid of those other 3. So reducing the number of medications is a big part of that. And then we start with therapy classes, which we'll get into some of the more high-risk classes. And so there's also a handful of ways to incorporate PGX into your program. Prior authorizations, pre-surgical prior auths, especially on the opiates. We're looking at age-related toxicity, so maybe identifying just the older population with certain medications. Talked about polytherapy, and then looking at disease states. So if diabetes is a big issue within your program, maybe start there and say, okay, we're gonna work through the diabetic patients first, then we'll get to the rest of the population. So the highest of high-risk classes, also common health issues within this country and within the program. Cardiology, pain, oncology, mental health's a big one. Antidepressants, talked about. The use of antidepressants is increasing rapidly. One example of a ultra rapid metabolizer of an antidepressant will have the reverse effect. So you go from thinking you're treating antidepressant or depression with an antidepressant, and you're getting the reverse effect because too much of that medication will make you more depressed. And so another concern within, I think, antidepressants within college-age students is increasing rapidly. And so a lot of that you'll see the suicide rates tied to this increase in depression and use of antidepressants. So it's something that needs to be looked at and considered as well. Health benefit of the members. So a recent study came out that 90% of the drugs on the market only work in about 30, 40, 50% of the patients. Obviously a pretty new study. A lot of it, they're guessing, is tied to just the metabolism not being able to break down the drug. So really, you know, the health benefit for the member is what's up there. I mean, it's reducing adverse events, it's increasing quality of life, it's reducing post-surgical complications, it's increasing productivity, it's decreasing absenteeism, decreasing the number of medications, and then what we just talked about, lives saved. And that is, if you can avoid one death from a PGX test, it's probably a good investment. Just a few numbers on productivity for hourly and salary employees. Average cost savings about $3,600 for an hourly employee and about $2,600 for salary employee. So medical cost savings, drug cost savings, absenteeism, productivity savings. that number really starts to develop, and this is why we're excited about PGX testing. I mean, the cost savings from one drug to another is good. This is the next level. This is okay. Let's take it even further and get medical and productivity cost savings. So a lot of this we talked about, lowering the cost, post-surgery readmissions from either not managing the pain or not being able to recover because of the pain, and elimination of drug events is probably the biggest of all of them. So what we did is we took ERS's report for fiscal year 17, and we went through there and we said, okay, we identified hospitalizations and diabetes as two big cost drivers within your program. Especially for diabetes, there's our PCM savings program of using lower cost alternative medications. And then there's also a PGX component to being able to get diabetic patients on the right drug at the right dose. The top traditional drugs we pulled out of there, just identify which one had PCM savings opportunities, which one had PGX savings components to it. A lot of them are both. Specialty drugs, a few more PGX related components than there are PCM. But out of the top 10, there's a lot of savings opportunities within those, and also the ability to improve care with those. So analytics. So this is our third prong approach to cost savings, and what we're trying to do is give you visibility into where all the money's going. If we can show you where every dollar's going, and you guys can go back and have the conversation of, hey, this is where we need to focus, this is where we need to spend our time, this is where maybe some things don't make sense. Really what we want to do is, with those analytics, is just be an unbiased third party that says, here's the data, here's what the information is telling us. Then you can have that conversation to say, okay, this is maybe some changes we want to make. And it might be, hey, this is what it is and we can't do anything about it. At least we know and we're good with that answer. And so our analytics tool is really digging into every aspect of that. So from pharmacies to physicians to the claims, to the performance, to, like we said, there's a lot of savings opportunities where, whether it be cash, whether it be just different or lower cost alternatives, whether it be lower cost NDCs. There's some NDCs that are priced extremely high, and the rest of them are down there, so we want to make sure we use the lower cost ones. So with that, like I said, you're just trying to objectively create a conversation to be all headed in really what we're calling true north, and that's just the right direction. That's really, if we can tell you the real story behind it, it's an extremely complex industry. We get it, we understand, and all we're trying to do is just provide that data, provide that insight, and what you can do with it, I think, would be powerful. So for what PCM and what we can do, like we talked about earlier, the free savings analysis. It's a great place to start to look at, hey, is there enough money to even to keep this conversation going? And if there is, how much? And I think that gives you the ability to say, okay, here's some real dollar savings we can discuss and talk about how we go after them. We have several different approaches, but that gives the ability to say, yeah, there's a starting point. Let's move forward. We try to make the barrier of entry about as low as possible. Our fee is guaranteed 100% to make sure that you're not spending money that you're not getting a good return on. And so part of how we price our program and how we set our program up is based off that analysis, so we can see how much work there is, one, for us, what the savings opportunity is, but to also make sure that you guys are getting a good ROI. There's no point in doing it if you're not. So if everything at the end of the day is even, you know, and there's no loss to it, we think that's a safe bet to go and make, but we're going to try to obviously outperform that as much as we can. And we try to make everything, the implementation about as seamless and as easy and as less work for, you know, a lot of you that have to deal with the implementations. We understand those can be sometimes time consuming, and you know, implementing another program sometimes just doesn't seem like the best choice. But we try to make that as easy as possible, as less work as possible. We'll take care of everything as far as the implementation is concerned, and really make it turnkey. So at that time, we'd really like to take questions and have an open conversation about the program, and go from there.
Thank you for the presentation. We'll open it up for any questions from the team, and I'll go ahead and start. You just touched on the implementation process. Can you go into a little more detail on how this service would be implemented in conjunction with any current TPAs or PBMs?
Sure.
Sort of things?
Yeah, absolutely. So
Dive into that just a little bit, please.
on our PCM savings program, what we do is after the contract phase is done, we sit down with the group and say, okay, between your formulary, benefits design, your member communications, we'll sit there, fully customizable, saying, how do you best communicate with your members? You guys tell us, we'll work with you to make sure we get the word out that this program's starting. We'll also take your existing program, no changes, and we'll make sure that we're not conflicting with any of the existing benefits in there, formulary designs, prior auth step therapies. We'll go through all that, make sure that we're not moving somebody to a higher cost medication or stepping on anybody's toes. So we'll run alongside the existing programs. As far as the implementation, we need two things, a claims file and eligibility file. We work with the TPA or with you guys to set that up. And then from there, we go. And we start to communicate with the physicians and the members, and then report back to you. So really, once that automatic file feed is set up, we just take it and run. So
when you talk about getting them on the lower cost drug, are you primarily talking about brand to generic?
most of it is a therapeutic alternative, which usually is a generic. So in most cases, there's enough generics in the market that we can get them off the high-cost brands onto a alternative that's a generic. So not to be confused with the.
I'm not talking about a direct generic from.
Right. Yes.
Therapeutic or otherwise.
Yes. Yes.
And so what do you consider to be a reasonable generic dispensing rate for this
A reasonable dispensing rate
generic?
for the pharmacy.
Well, for the plan, I mean, what percentage of drugs?
We're seeing anywhere in the mid-80s right now, upwards to 90%. So even with that, there's a lot of cost savings opportunities, and a lot of our analytics, we're looking at maybe 10 to 20% of the drugs are making up 80 to 90% of the cost.
And so you're looking at cost with or without rebate?
With, so we want the lowest net cost.
So how are you gonna get the rebate?
So we either take the data that we have, or if you guys provide it to us, we'll incorporate that in.
So data you have would not be our rebates.
No, but a lot of that information is published, and we can pull that and
Be like straight line average.
yeah. Yeah. If it's something you want to give us, we can actually plug it right into there and know exactly what it is. And that's part of the analysis and the calculation is to calculate that loss in rebates. We're not switching people for $10. It's not worth, our time. It's not worth the hassle from the members or from the physicians, knowing that if there's a rebate on the back end, that brand drug is going to be the lowest net. So we're looking for the big spreads.
So you're looking at primarily mid-80s after rebates is considered a good.
Yeah.
So you mentioned that, excuse me, that you're not gonna move people to the higher cost meds. What if they're PGX? Are there ever scenarios when the PGX says this person would do better
Yes.
on this drug? So what do you do in those situations?
Well, for one, I think it's the quality of care has to be taken as the first line of defense. So if you think about, if they're on a more expensive medication, but the side effects are lower, the doctor visits are lower, the lab tests are lower, the overall net cost is going to be lower from being on a more effective medication. So with PGX, we look at it a little bit differently. The PCM savings program, we're looking from high cost to low cost. The PGX, yes, we're looking for the highest quality first to be able to treat that disease and if it is a higher cost medication, well, the overall cost savings from the back end of it is going to be significant.
But you do notify the physician?
Yeah, so what we'll do is we'll work with the member to however that information needs to be realized, whether the member wants to take that report into the physician's office and say, hey, this is the report I got, this is what it says, and make those adjustments, whether they want to work with one of our PGX trained physicians. It's really up to the member at that point. We'll assist them however is needed to make sure that they understand what that report is telling, and if there are switches or changes in treatment, that we're helping them along the way to get those changes implemented.
So I have a question specific to the PGX
Mhm.
test. So, do you know about how much that test?
It's $485 for what we charge with the telemedicine component, with the 2 consultations, and so we've packaged that up so that people are more comfortable. So when you talk about DNA and you talk about hereditary and people, there is a fear out there that the DNA is going to be used against them, whether it be for employment. They're going to get fired because they have a hereditary marker that says they're going to have Alzheimer's and they're not going to remember anything, and the employer's going to fire them. This doesn't include any of that. This is just what gene interacts with that drug, but we've done it so that people feel comfortable taking that test at home. Everything's done in the comfort of their own home through telemedicine and through the lab.
So, let's say that somebody gets their test and 3 months later, the doctor changes their medications. Does that result in another PGX test?
No.
For the new medication?
No.
At what point would they have to have a second PGX test?
So if there is a new gene discovered that is interacting with a drug that has not been tested, then a new test necessarily wouldn't be issued, but it would be done in the lab. So that oral swab is kept and that DNA is kept for that test to be added. So on that report, so that portal that we showed you where the report is, drugs are being added to it as they come out, as they're being mapped, as they're being understood of how they react with drugs.
Yeah, so that's my next question. So I'm sure you run into experimental investigational pushback sometime along the way, like for Medicare intermediaries perhaps for some of these. So does your plans that you work with today, do they just cover the experimental investigational to give them savings?
That's really up to the plan. So what we base it off is medical necessity and the physician saying, yes, this is medically necessary. And we've taken that to say, okay, we're going to identify the highest of risk drugs first. That's how we're involved in communicating that to the individuals. And so really what we want to take is, okay, we know that some of these blood thinners are going to build up some toxicities, and it's almost guaranteed a hospitalization, right? Average hospitalization, $10,000. If we can avoid that hospitalization beforehand, we want to go after that population first. And so those are the ones, the experimental, we're not getting involved in. We really want to know these drugs are rated.
So for example, using your illustration, a Medicare patient on warfarin, whatever the gene is considered investigational by Medicare. How do you work with the plan to get that covered?
Just like a prior auth. So in your plan, summary plan description, you're going to outline how you're going to cover for the PGX. And if that falls outside of it, then it becomes your prior auth procedure, or if a member just wants to go get the test because they think it's interesting, that's on the member to pay for it. And so it's going to fall within your guidelines, appeals processes, how you go about saying, yeah, we'll cover this for the individual. But really, you know, these are the high risk, the highest of the high risk categories that we consider that says, look, there's some pretty significant issues with these medications and how they're metabolized with individuals. And let's start there. And let's make sure we're treating that population. We're trying to reduce the number of hospitalizations. We're trying to reduce any of the big adverse events or big interactions that are really the high dollar medical side that these are causing. And from there, we can work through the population and say, okay, over the next 2 years, 3 years, we'll get through everybody that's at risk or everybody that's identified by the FDA as being eligible or needing a PGX test.
So, I wanted to ask a question about that statement. It sounds like you're saying that the FDA recommends the PGX test for certain drugs?
Yes.
Specifically this test?
Yes.
So this test is, I saw you had one study with the 50 patients in this presentation, but is there any other, like how many studies that have been done to support, the effectiveness of this testing?
Right. So and to give you some background, so where the labs are going is CPIC and the Dutch Working Group, which is the European version of our CPIC, is really the scientists behind all this, the governing body that's trying to set standards for all this to say, this is where we need to go. This is the research. This is the repeatable studies that are showing this gene is interacting with this drug. And so the labs then will go and they'll focus on that. They'll do their studies on there before those are ever implemented as part of the list of drugs that are tested for PGX. And so what we're doing is we're saying, okay, the FDA already has black box warning on these drugs. We're focused on those. Those are kind of your first line of defense. And then your second line is the CPIC and Dutch Working Group saying, this is pretty significant as far as the repeatable studies, the large enough studies that have been published, usually multiple publications around the country or around the world. And then from there becomes the other studies that have been done that may be not as advanced as say the CPIC or the Dutch, and then so we're working our way through, and our lab is working our way through those drugs and those genes. So there's some labs that say we have 200 drugs, but maybe 50 or 60 of them are maybe questionable. We're trying to stick to the ones that we know for sure that are rated A, that says absolutely this is a gene that interacts. We know how it's been studied for years. Those are the ones we're focused on, and that's where we're starting. And as this science evolves, and maybe take 10 years before there might not be a drug in this country prescribed unless you have a PGX test. We'll get there. It's just going to take some time as that science evolves, as that mapping evolves over the years. But for now, it's starting with this foundation and this base, and then building from that.
How is this test different from the DNA type test if you're diagnosed with cancer? And so they're going to put you through a DNA lab test to see what, to get more information, what kind of chemos you might respond better to. Because I know some of those come back as being not medically or experimental investigation.
Right. So
And
the
those are huge cost difference, because those are like
Yes.
$1,000 versus your $500.
So it goes back, and I'll use the breast cancer that some of the more popular hereditary tests are doing, to where they're looking at 2 pairs of genes. There's a 12,000 pair sequence where breast cancer can present itself. They're just looking at the 2 most common. We're seeing it more on these 2. And so when you start to get into the science of DNA sequencing versus mass array versus PCR, and how they're actually testing for this, and DNA sequencing going through absolutely every single thing to make sure that breast cancer does not show anywhere in the long string possible. Now, if we take, the 4 billion for DNA possibilities, you start to sectionalize that, and it really depends on the lab, it depends on the test, it depends on how they're doing it. But that DNA sequencing was which our lab uses for the PGX component is the most comprehensive to look at every single piece of it, all the molecules involved in it, to really say, okay, yes, this is what's happening or not happening.
So can I just want to make sure I'm clear. So, and I'm not sure I'm referring to what you're talking about, but you're not talking in your presentation about blood and tissue DNA testing for cancer markers, et cetera, DNA.
No, we are not.
You're talking about a $485 mouthwash swish, send it in, find out if a drug may or may not.
Correct.
I mentioned just one of your examples, this child who was prescribed an opioid. I'm assuming this is not that fast. You're taking, somebody's been prescribed a medicine, and so they come up on the claims file, and you see that they're taking this medicine. So it's not pre-prescribing of the medicine.
No, so if we go back to the different ways to implement the PGX testing or incorporating the PGX testing in your program, there's really multiple ways to do the PGX side. Our PCM program works retrospectively. We see it in the claims file. We identify, flag that, reach out to physicians, get approval from the physician, reach out to the member. So that process is done retrospectively. There's no waste in the system. It's continue the medication you're on. Once you're finished, the new medication will be there waiting for you to pick up. With PGX, there's a lot of different ways to go about it. You know, with a child, it's difficult because there's really no reason to test the child unless they're on a medication or have issues already. But it's something to be aware of with opiates and with the way that the opiate epidemic in this country is why we brought it up to say, you know what, let's try maybe just ibuprofen without the opiate to it or the narcotic to it. Or have that test done before a surgery or before you continue on with that to make sure that you don't have the overdose, that you don't have the adverse event. And so as we work through the population, there's certain things that, for me, I'd say pre-surgical prior auth for opiates makes great sense, just because of all the benefits to it and all the issues tied to it that could be eliminated or reduced. And so it kind of, you just pick and choose, create the conversation, say this makes sense to us as a group.
Time is quick enough to do it in a pre-surgical.
Yes, yeah, absolutely. And those tests can be done, under 5 working days between you have the consultation, you get the test, and you get the results back and have that conversation. It could be done faster, expedited sooner, should this come up late stages right before surgery.
And with the ways that you're saying to incorporate it, that would be, so let's say you did the prior auth, right? But if I said, no, I'm good, I don't wanna take it, right?
Yeah.
Like then, so let's say you do that, right? And then you get prescribed a medicine, and then retrospectively, that medicine pops up to where it could have been one that could have been, maybe the generic, I guess, if you will. Would you also turn around and say, I guess still offer the generic even though I chose not to have the PGX test?
Yeah, and that's a plan design, I think, more than anything, where the plan would say, let's keep this pretty open. If they want to go back and do it, sure, absolutely. So that's more plan design than anything.
Can you say a little bit more about how you calculate your savings?
Sure. So, what we do, and this is analysis, the math, the theory behind the actual production is similar, same. So we look at every single claim. We have proprietary software that we're able to go through every single line in the claims file that's given to us. From there, we look at how many potential cost savings opportunities there are. We call those identified alternatives. In this case, $132,000. From there, the current cost is the actual cost that was paid for by the plan. We take that pricing right out of the claims file, It's not our industry pricing, it's not our pricing, it's your pricing that we use. And the same for the proposed drug costs. So at 100%, here's all the alternatives, here's the cost difference between the two. And so that's where we come up with that savings number. Now in a production, if you're prescribed drug A, the target, we retrospectively work on it. We get that drug changed. When that file comes in, we see that you made that change. We take that price that was actually paid for the drug, and then in that given month, the target that was the same drug, same dose, and calculate the difference. And then every month that gets updated, so that if there's a big price reduction, the savings drop. If a member goes ineligible, the savings go away. And so it's a true month for month, line for line, drug for drug, we call it, of auditable savings that says, yes, this switch was made, here's the true cost paid for by the plan, and here's that savings.
So that doesn't even include potential hospital visit avoided.
Right. And so we're working on how can we actually start to look at the medical side to say, you know, it's hard to predict or calculate preventable instances, but, you know, being able to take statistical data on the medical side to say, hey, how we incorporated PGX and hospitalizations dropped 10%. Okay, we know some, but we're not, you know, we're not charging on those savings, and we're not trying to take credit for it, but we will look at it and say, hey, look, this is the benefit we're seeing since the program has been implemented.
Just to be clear, this slide is PCM savings, not
Yes.
PGX savings.
Correct.
Which would, I think, to your hospital avoided would be for that other program. Just a quick question, that current cost, that 58 million, is that, in this slide, is that supposed to be net of rebates, or is it only? in
It
the
depends
bottom line
if,
savings?
if they're given to us, we'll incorporate them in.
Okay.
If they're not, that's the gross.
Okay.
And so we're down below, you're seeing we're netting out industry average rebates from there.
Got it. And I had a quick question back on PGX and just like how you envision long-term this going. I mean, it's a little bit unusual to me, I think, where you're getting the plan to sort of directly cover this as opposed to, I guess, you know, I mean, if this is a test with medical value, I mean, I would think in the normal course of business, you go to your doctor, the doctor says, hey, I want to prescribe you this, but I know that there are some issues for different people with, you know, different genes. So I'm going to have this other test first to see what drug we need to get you on to treat your condition, and then they
By the way,
prescribe the test.
What you just described, we're not even covered by our plan design as it is today.
No, I understand.
Okay.
I'm just saying, as far as your strategy for PGX, is that where you see it ultimately being? Like, most things,
I think
the
you,
doctor controls it?
yeah, and you can have, the problem with the science is fairly new. A lot of the physicians, it's counterintuitive. All right, if you've spent so many years with trial and error prescribing, and the way that the system works is that I give you a drug, it doesn't work, you come back and we figure it out. This kind of goes the other way. This is the patient's genes telling the physician what to prescribe. So it's kind of a little counterintuitive from a physician standpoint. That's why the telemedicine piece with the PGX trained physicians are able to have that conversation. They understand the science a little bit better. Not to say that primary care couldn't order the test as well. As far as the setup, once again, that's plan design. So if you just add it to your lab testing currently, and it might be an 80-20 split, it might be a 50-50 split, that can be set up, you know, that's all plan design, how that sets up, where does PGX fit into your plan design, how is that, you know, covered between the plan and the individual. With the amount of cost savings on it, you know, it's a decision that has to be made that says, do we want to cover a majority of it because of our long-term savings on the medical side?
Yeah, I'm not sure where else we'd go and tell a member to go get a lab test or medical care. You know, usually that's all handled
Right,
in the
so
physician's office, and then we, you know, we'll have rules on whether or not that was appropriate, and we should cover that, but we don't normally direct.
right, so that's where PCM comes in, where we're looking at the high-risk people. We're doing the outreach to them that says this is available to you through your plan. And we're not forcing them to do it. We're just saying, presenting the information that says, hey, this is an FDA black box warning. It's recommended you have a test done because you're on this medication. Whether they want to take it or not, it's up to them.
So I have a question about that actual test. Who owns the test?
The labs,
Labs?
the labs, they're gonna own them.
So technically, anyone could probably go direct to a lab.
Yes.
Although they're probably, I think in terms of like, they're probably out of network for most
Correct.
carriers. And the lab owns the test, but yet we would pay you.
Well, no, not if they go direct. So if they go direct, you can go
But if they
direct and
don't
get the
go direct,
test.
if they don't.
Correct. So,
And your part in that is,
so it's a strategic partnership that we're able to do the analytics to identify. We already do the outreach for the PCM program, so it made perfect sense for us to transition or to include this as part of our offering. Just because we're able to do that outreach, we're able to say to the member, hey, look, this is a high-risk medication that maybe this test is something you could take, and they have the opportunity to go speak to their primary care, their specialist about it, to see if it makes sense for them to take. Really what we want to do is present the information that if you went to an individual and say, hey, your drug has a black box warning. You know, what does that mean? You know, what am I supposed to do? How am I supposed to? So we're trying to help the member navigate, you know, the system a little bit better, present the information out there, and it's all voluntary. And that's really how our processes are set up. It's 100% voluntary, totally up to the member, totally up to the physician. We're just presenting information in a way that says, either this is a cost savings opportunity, this is a health related opportunity. Most of the time it's both.
And what does that interaction look like between you and the prescribing provider or the member?
And
Once you've identified a potential cost savings.
Right, so part of the implementation is we work with you and say, how do you best communicate with your members? And so it could be a letter, it could be a text, it could be an email, it could, you know, we can do it a number of different ways. What we like to do is sit down with the group and customize that, because you know your audience better than we do. You know your participants and how and what they look at and what they listen to. And so we try to work with our clients or with a plan to say, what's the best way to approach them? And we have multiple ways that we can communicate.
We got time for just a couple more questions.
I'm gonna ask one more real quick. How does if somebody implements your company, work with step therapy in their, in their prescription drug program already, and step therapy's there for the high cost, majority high cost specialty drugs.
Right.
Can going through that test be a more direct way for that patient to know what is the right drug for them, rather than going through the step therapy process?
Absolutely. And that can be incorporated in as, I mean, if you're going to prescribe a $5,000 or $10,000 a month drug for $485, it might be worth the investment to say, we're not going to waste even 1 month of a $5,000 medication for $485 to say, we might be able to say that's going to be totally ineffective. Let's go to the $60 medication. So your ROI on that is huge.
Any other questions?
All right.
All right, well, that's all the time that we have for today's session. I want to thank PCM for being on site today. Also want to thank the staff that are here in attendance. We'll see you next time. Have a great day. Thank you.